Growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, it's Dr. Steve Rasner. Welcome to episode number 3 of The Lionhearted, those who refuse to quit. Listen, I want to begin by saying I know you're probably on your way to work right now. Most of you can't physically see me, which is perfectly fine. And maybe you're going to the gym, whatever it is. And I'm also sensitive to the fact that there are now, I think, over 100 different podcasts that you could be listening to. And so, your time is precious, and I'm sensitive to the fact that you have many options. So I'm going to try to make this as much as steak and potatoes as possible. So enough of that stuff. Listen, if you tuned in to episode 1 or 2, you heard me talk about the important service protocol. In other words, the services that you offer of oral sedation. I'm not going to repeat that so much at this particular episode and the details of it, but except that I want you to be sure one of the takeaways is that you cannot just dispense the medications I discussed on those episodes. You have to get a permit from your board of dentistry. So all you got to do is go to your front desk staff member on Monday, tell her to call up your state board of dentistry and what are the requirements for oral sedation in your particular state. And the reason I'm saying that to you right now is because it serves as the basis of case acceptance, which is the next several podcasts I'm going to go into, because I don't think anything, I know for a fact it's the fuel that determines what kind of practice and how your days are spent and how your weeks and years roll out in your particular practice. Yes, case acceptance is that, because if you're not getting great case acceptance, then you will have a practice where you deliver single tooth crowns all week sandwiched in a malocclusion dentition. You certainly will, or you're very vulnerable to developing an insurance-driven practice, which leads to burnout. Listen, it's hard for me to stay on track all the time because so many thoughts are in my head as I speak to you. But the basis for me doing this, the reason I'm here right now on a Saturday morning trying to fire off a couple podcasts to you is because I want to make a difference. I mean, what else would I do this? These are obviously no cost. And I want to influence as many of you as I can for whatever reason drives me to do that. And so the way to do that is to try to give you the blueprint that I've developed over the years. And those of you that are familiar with my journey would know that my journey is that I took a practice in a very difficult part of the United States to be successful in terms of economics. I mean, everybody that comes into me, almost everybody virtually, getting them to do anything they want to do is just not realistic. Money and finances comes into play on most of the treatment plans I do. But I certainly know that how often, if you hear a kitty cat in the background, I'm at home today. I certainly know that your case acceptance is fueled, is impacted by many, many factors that you can positively influence without a lot of cost or anything. And just a quick example is, a lot of us were led to believe back in the day that we should have this fancy consultation room. I remember it vividly, and you push a button and a screen will come down, and you push another button and you'll be able to show videos or slides of a case that's relevant to the patient that you're trying to explain case acceptance to. And in my opinion, and then often that room is supposed to be decorated pretty nicely, even a fancy desk, and it was supposed to look like you are very state of art in everything, including your taste and fashion and I guess office design. And I'm here to tell you that that may work, but it's I actually think it's a negative. So one One quick thing I want you to get this today when you're listening to this is you don't need a fancy office and certainly don't need a fancy consultation room. And on top of that, you don't need a myriad of expensive, sophisticated tools to demonstrate to patients, in my opinion, what you're trying to explain to them in terms of case acceptance. And as these episodes unfold, you'll see exactly what I mean. You'll see how I use a $5 mirror that you can get at CVS or Rite Aid, and really good verbal skill and communication skill that really there's second, that if you have that skill, it's second to none, anything else that you have. And so a lot goes in that equation. So let's get to it. Let's begin our talk about case acceptance and how do we get that. And I'm going to begin with the first phone call because that's where it starts. Naturally, that should be obvious to you. You're never going to get a chance to examine that patient if the first contact in the office turns them off. So the very first thing for you to do is go back and rethink, do you have an amazing person assigned to that new patient phone call? Now, I have 21 employees in my office, and there's only one that I want to take that call to completion. If she left me, if she moved, if she retired, I guess I'd have to figure it out. But, until that happens, it's no different to me than wanting, a top quarterback, I can't think right now. And I'm a sports fan, oh my God. Whatever city you're in, whatever your favorite quarterback is, that is the role of this new patient contact. And often that new patient coordinator plays a role in a myriad of other things in your office, as does mine. Her name is Michelle. And while we're at it, I guess, if you can write this down when you get back home, Michelle, Michele, at Pearl Smiles, Pearl, smiles.com. Beth can probably get this on the screen. And you should ask her a number of things I'm going to cover in these next episodes, which would include, what is the right verbiage? How do you really speak to a patient that's out of network and still have them often come to you in spite of the fact that they're out of network? What's the language you use? Do you say, listen, you're out of network, just come to us because we're better? Of course not. Another thing that she would discuss with you would be, how do you get the significant other to come to the first visit if we think it's indicated, which is almost always? How do you make that happen? What's the words to use? And I'm going to cover each of these in a few minutes. And then lastly, as we'll get to later episodes, is what would be the verbiage to getting patients to be okay with paying you up front. And that's going to be a whole episode itself. And I don't want anyone to think for a second, I want to get paid up front because I'm greedy. Getting paid up front solves a myriad of other issues, including broken appointments. And in my opinion, it's not only the right thing to do, it's the ethical thing to do. Because when you set up payment plans for patients, which I did from 1980 to 1995, that's 15 years of evidence, you often, so in other words, a patient will pay you X amount of dollars over 10 visits or 12 visits or whatever the treatment takes over a period of 4 to 6 months, whatever it is. So often that treatment never gets complete because the patient has personal priorities in their life that interrupt treatment, and nobody wins that way. And quite honestly, either you can afford the treatment or you can't. And if they can't, in the long run, both of you will be better off with never starting the treatment. And you'll hear me say that a lot, and that's because I've been doing this for 38 years. And there's probably more than a handful of cases I started that I probably wish I hadn't started. One thing you got to get out of the way is, can they afford it? Are they comfortable with that investment? I mean, it may be taxing to some people, but they want it so bad that they're still going to do it. So we'll get into that later. But let's get back to the first contact, which would be the new patient phone call. And you got to remember I started this episode a few minutes ago by saying to you, reminding you that I have a heavily influenced oral sedation practice. So why the reason I said that to you is a lot of times the patients calling me have heard an ad on the radio, they have seen print media or some type of branding of mine that reminds the public that yes, we sedate patients, and I'm talking about oral sedation in our practice. So naturally, a lot of the people that are calling me know this, and they have a fear background. So and we're so successful with those patients that it's, and Michelle knows this, my new patient coordinator. So it becomes an incredibly easy process to get them to try us out. And we'll get into the details of that as we go on. So this person that I want to answer that, you need to look and see if you have this person. If you have somebody that's moody, somebody that's hot, really tremendous 3 days out of the week, and the fourth day of your week, you never know what you're getting, that's not the person for this job. I would not be the person for that job, quite frankly. So you need somebody that person in your practice obviously has a very nice voice. They sound like they're smiling when they're talking. They're a people person. They can bond to just about anybody. I think most of us have maybe, I don't care what role they play in your office, I would very much influence you to try them out in this position. And if there's any doubt in your mind, you don't have the right person, then you don't have the right person. Okay, this is so critical as we go on. I can't tell you the number of times a patient may have come to us and ended up with an extensive treatment plan north of $25,000, but called with the complaint of the last dentist, wanted them to spend $3,000 or $4,000 and take a loan to do that. So naturally, the process has a lot to do with the end result. So they call up Michelle, and this is, I'm not going to give you literally how the call goes, but after bonding and getting basic types of information from her, from the patient that called, the patient may mention that they live in a neighborhood. Michelle is one of these people that knows the neighborhoods. I mean, in a 30-mile radius, she knows a lot of things I don't know, and she can strike up a conversation, or where they work, or we once had a patient from that worked there, and obviously HIPAA permits us from being too specific, but I have to tell you, this isn't just idle talk. They're called common bonds. People like to do business when they find out other people they know and like have done business with you. That shouldn't come to you as a surprise. And I'm sorry to bog you down with all these details, but every detail I'm talking about to you counts right now. So as she's going through what she has to do, the basic information. So where do you live? And, how did you hear about us? Where do you work? And those type of things. She can make conversations that are very, very natural to her. When I walk by her, it seems to me as if she knows this person and has spoken to them for the third or fourth time, but it's really not the case. Then she does something that I call a mini dental history, So she's not just going to say, as we all know, the patient calls up and is either going to say, look, I just want to switch dentist, or I just need a checkup. But often they'll say, I broke a tooth, I have pain, or such and such. And that's not where it ends for us. If you're watching this on YouTube, yes, you're going to see a kitty cat in the background. Sorry. I'm doing this from home. So, the mini dental history will go like this, and it can be specific to what type of practice you have. So, for example, I don't have a very heavy TMD practice where we focus hard on patients with hot muscles and stuff, and so that your questions could be different for you. But I am trying to get as much information as I can about this patient that I've never met. So this is how that unfolds, and it's very basic. And we've done this incidentally really have done this form of this for every bit of 25 years. And she'll start by saying, so let me ask you a couple questions about your mouth that'll help us be more prepared for you. And she'll say, and these questions hopefully Beth can get up on the screen for me when this is edited. When was the last time you visited a dentist? Well, naturally, it's going to influence me a little bit. I had a patient 3 weeks ago, 32 years old, that never went to a dentist. That was his answer. And we had to clarify that to make sure that we were accurate. But yes, he had never gone to a dentist. Others very commonly will tell you, well, I haven't been in 3 or 4 years. Somebody may say, I go every 4 months, you're going to love my mouth. That has an impact on what's going to come next out of Michelle's mouth. She'll ask, if you had to guess, how would you say the health of your gums are? Do your gums bleed at all when you brush or floss or anything? She's doing all this to give me a cliff notes of this patient before I get to meet them, because the more I know about them, the better chance of acceptance of case acceptance. Then she'll say, do you have any missing teeth? And if the answer is yes, do you wear anything removable, or do you have anything fixed that replace those teeth? Again, I'm getting, do they have any bridges? Do they wear partials? A denture? And then of course she'll ask, and how long have you had that? And are you satisfied with those? How do they work? How are they working for you? Okay. And just again, she'll go on. I don't remember all the whole 5. Might ask them how do they feel about their smile. And I have to tell you, we've been doing this, as I just said, quite a long time. And I've never had her say to me, hey, somebody just hung up on me because I was asking them too many questions. It just works if you have the right tone of voice and you have the right person doing it. Okay? The next thing that she'll say, which I believe is truly critical, is she'll say this line, and you should use this line. Michelle will say, well, this is how the first visit is going to work. I'll say it again. This is how the first visit is going to work. Dr. Rasner will take a look at not just the tooth you've called us with, but all your teeth. Now, why does she say that? Every single thing I tell you, everything I practice, everything I've written in every book I've wrote, is because I once didn't do that and it came back to bite me. So all of you listening, I probably have had the hygienist walk in the room of a new patient you're about to see, and they said they don't want me to look at their whole teeth. They just want this one tooth treated. Well, that's not the kind of practice I have. I haven't heard this advice in a long time, but I know there's some out there that say, hey, listen, take care of whatever problem they have to the best of your ability and have them come back, trust you, and bond with you. I couldn't disagree more that that's not what you should do. And I'll get into that a little more later. So that's why she says on the phone, Dr. Rasner's going to look at all your teeth and check everything out. If they even have the hint of a negative response to that, your answer should be, listen, I've been with the doctor quite a long time. And if you've only been with them for a couple months, then think in terms of seconds. Because what I'm about to say is 100% true, whether you've been there for a week or 38 years like my Michelle. And that is that they will save time and money if the doctor looks at their whole entire mouth. And we know that's true. Those of you in practice, think about the patient that you have that they may have a second lower molar that's got a root canal and a crown on it, and it's almost tipped at a 45-degree angle because the first molar is missing. And that is the result of myopic one-tooth dentistry. That patient went into an office somewhere, had pain in the lower second molar, and the treatment plan for that tooth to get him out of pain and restore it would be a root canal and a crown, when in fact it might have been inappropriate treatment. And I've got more than a few of those in my practice that I've seen. So you have to look at the whole mouth to make even a half reasonable recommendation on this. So I don't treat, even if it's an emergency. And I wrote an article called The Hidden Jewels about 15 years ago. And the hidden jewels, which I don't get many emergencies anymore. The climate has changed. Maybe they go to urgent care. I don't know. But certainly in my first 20 years, I got plenty of emergencies. And the way I used to handle emergencies, and this may work for you if you get a lot of them, is I left 45 minutes to an hour blank in my schedule every day. Now that's, I don't know if I would do that on purpose in 2018 or not. And then when that new patient came in, that was the emergency, we gave them a new patient experience. And it blew their mind because most emergency patients have been emergency patients their entire lives. In other words, they're not great patients. And they only call the dentist when something hurts or is broken or chipped. And they are usually treated like the not so good patient they are. So they're jammed into somebody's schedule. They're made to wait. The process is always the same for them. They're second-rate dental citizens. They get an emergency treatment plan, maybe a pulpotomy, maybe a quick tooth extraction if possible, and then they're off to the next time. And I wrote an article based on a different approach I took over the years, and it doesn't work for all of them, but I gave this patient a chance to be a different patient, a patient who cared about their teeth going forward. And so I gave them adequate time. I scheduled and treated them as if they had this appointment weeks in advance. And it worked very nicely for me. A lot of patients who otherwise would have just had a tooth removed or a pulpotomy started became long-term, pretty good quality patients. That being said, I don't get that many of them in the last several years. So I don't think anyone listening who knows my philosophy of getting to a successful practice would argue that looking at the patient's entire mouth is mandatory to any treatment plan, even if the treatment plan involves one tooth. Because quite frankly, that tooth that they came in with, the second molar that I gave you an example of a few minutes ago, may end up being extracted. That may be the best thing in that patient's mouth when you examine the entire mouth. So, yes, the answer to, well, I don't really want all that, I just wanted this one tooth treated, would be, well, you know, Mrs. Smith, I've been with doctor a long time, and I am positive you will save both time and money on this tooth, on what he decides to recommend for this tooth if he looks at your entire mouth. And if they won't accept that, which I can't remember the last time that happened, then we will recommend that perhaps we're not a good match for them. And that's a big thing for me to tell you in these days, because, you know, new patients are hard to come by, and new quality patients that value the type of exam I want to give them and the type of services I want to give them are even harder to find today. So it's not easy for me to say this to you, but I'm positive from my philosophy that it's the correct thing to tell you. The second thing we'll say is, remember, this is follow-up to Dr. Rasner's going to look at all your teeth today. Follow-up to her saying to you, to the patient, excuse me, this is how the first visit's going to work. So she explains we're going to look at all their entire dentition, their entire mouth. She doesn't say dentition. And then the second thing she's going to say is, and he's going to take whatever necessary x-rays he thinks he needs to take to give you an accurate recommendation. And again, I try to use very friendly patient terms as we speak in southern New Jersey, or probably anywhere I would practice. So when you say that, a lot of patients may say to you, oh, I just had all that done. You know, I just had the full set of x-rays done. And in my experience, that probably means they had bite wings done 11 years ago. So this is my thing on that point. When I talk about marketing at a later podcast, you will hear me say that free is the worst word a dentist can use in dental marketing. And when I say that, I mean implying a discount, is the worst philosophy you can use. So if I've done, how do I know? Ask me how I know. Okay, I've done it. So whether it's come in by the end of the next month and you'll get free bleaching or free console, 10% off if you're a public servant, 10% off if you're a teacher. I don't care what it is. When you imply a discount or free, it leads to really low quality patients that don't value your services. I've never seen it work in my experience. So the reason I'm saying that is because Michelle will say, when they say, well, I've had that done, well, doctor will take a look at you, and if he thinks he needs additional x-rays and it's not covered, there'll be no additional cost to you. We will just gift that to you. Now, by the way, you can't gift them and then submit it to insurance. That's insurance fraud, so don't do that. Listen, you can eat the x-rays if you have to. It's just not something I would ever advertise. You know, the patient, and the last thing I would do, and this may sound controversial, it may not sound warm and fuzzy to some of you, is last thing I would do is ask them to get the x-rays from their old doctor. Listen to me. That's a recipe for them to go back to their old doctor. Every patient you treat in your office, unless you got them at 2, you already got from another dentist. You did already. So don't feel bad about the pay. And you've lost an entire practice over your career, at least, to other dentists. It's just the nature of what we do. So look, as we'll get into later on other podcasts, what we do is elective. People, unless you often don't have to go to the dentist, they can put it off indefinitely. For goodness sakes, if they've taken the proactive steps to react to your marketing or whatever you're using, they've picked up a telephone, they've called you finally, and you're going to put them off for 3 or 4 weeks to get the x-rays from their other dentist? I don't think so. Not in my world. So listen, there's going to be several of these podcasts in a row on this. I don't know how many it's going to take me on the concept of case acceptance. I know personally it's almost at the very top, if not the top, of the positive ammunition you need to have a career that is filled with challenging procedures that are different every day by patients that paid for them already. You don't have to worry about them bringing the payment on Thursday or whatever it is. So we have to spend as much time as I possibly can to make sure I influence as many of you as I can to have a joyful practice. Thanks for tuning in. I'll see you at the next podcast.